Hello, my name is Hermine Hayes-Klein. I'm an American attorney and advocate for women's rights in childbirth. This work came out of my experience teaching law in the Netherlands at The Hague University from 2008 to 2012 and studying maternal health systems in my role as director for the Bankershoek Institute Research Center for Reproductive Rights. Now, my legal advocacy focuses on the enforcement of informed consent and refusal in labor and delivery, as well as the right to choose the circumstances of childbirth, including access to midwifery care and the support of doulas. I'm very honored and happy to be here in the Czech Republic, meeting with my colleagues to talk about women's rights in this system. So I'm excited to have this conversation today with Martina, the head of UNIPA, and Kristýna, the obstetrician. So let's talk about Czech maternal health care and some of the challenges faced here.
Yep. Thank you. So the reason we're here today is that there are some dysfunctionalities in our Czech maternity care system. And the thing is that it's not supportive of women. Basically, it doesn't respect their rights and their voice doesn't get heard. They are not the protagonists of their births. And so that's the main reason why we're here today, to address these issues. And since we've got this gynecologist here who is also experienced, she's the insider of the system, from the system. So I would ask her to comment on the situation here. What can be done? Like, if you could please maybe make us more detailed diagnosis of the system here, of what we are facing, what we are dealing with, and then how to address that, what we could do about that.
Of course. I'm going to give my insight. I just want to say that I'm like 3 or 4 years working in the system. So it's just my opinion that I'm going to give you here. And, we are so proud of the statistics that women, they don't die in childbirth, that we have good neonates. I also worked as doctor, as pediatrician for the neonates, so I know. But we just completely forget about the woman's experience of the birth. And I know about it because I also work as a peer consultant for the women with mental health issues, so that I hear their stories. I hear what the childbirth can do to them, to their personality, and how it can lead to depression and how it can affect their whole family. So I think that we need to realize it, because I think that a lot of obstetricians, they just don't see it. Because, they see pregnant women, they know that she needs to give birth, and they want her to be healthy, they want her baby to be healthy, and then it's it. They don't care about anything else. Yeah.
And I would probably add here that it's not perhaps about being healthy, because this is not even viewed here. It's in terms of the survival mode. They want them to survive, but they don't actually regard the both perhaps short-term effects of birth giving. This is something that they do view, that they take into account, but then long-term effects of their birth giving experience, and actually this is something that is not regarded. It's kind of disregarded. And so we would like to actually upgrade our system, maternity system, in terms of not just regarding the survival mode, but also really treat the woman as a partner and the protagonist of her birth-giving experience, and regarding also the long-term effects, both psychological and somatic, that this experience has on their lifetime or in their lifetime.
In a way, it connects to an expanding concept of maternal health, because something I think about as you talk about this is how, in the 1990s, the World Health Organization, it was the first time it ever recognized any human rights at stake in pregnancy and childbirth. And that's when, in the Millennium Development Goals, they recognized preventable maternal mortality as a human rights crisis. And that was looking at the fact that there were nations that just assumed childbirth was deadly. And so when women would die, they would say, well, it's childbirth, or they were just not investing in the health of women in a way that would prevent preventable death. And so the World Health Organization said, this is a human rights issue. Women have a right to survive childbirth. And what that translates into is that they have a right to access skilled obstetric care and emergency medicine. And so this was the 1990s, but they didn't recognize all the other human rights that are at stake for a woman in healthcare and in childbirth. And so from the 1990s really until, 2010, you could say, there was really this focus on mortality and survival. And I think what you describe is that the Czech Republic, along with other nations, really focused on what can we do with our systems to try to eliminate or reduce to minimum, and very successfully. But in the last 10 to 15 years, there's been emerging understanding all over the world, also by World Health Organization, United Nations, that survival is not the only human right at stake in childbirth, and that, in fact, if we only focus on that, then we risk violating all of the other human rights that are at stake in birth. And the violation of those rights, it doesn't just cause a negative experience, and in a way, I think that it's worth avoiding this dichotomy of like safety versus experience. It's all about safety and it's all about health. And I think what Kristýna's getting to is that in her work as a doctor, she also treats the mental health side of the picture. So in a way, what you talk about when you say, and the issue here is that the women are not supported, I could imagine many working within the system saying, what are you talking about? We do support them. We're trying to support them to survive. But what you're really talking about is support them in the full spectrum of their human rights. And what that means is most fundamentally their right of autonomy, to recognize that this is a human being birthing a baby, accessing care, and they must be recognized as a human being the whole time. They cannot be an object to be processed. It's when women are treated like objects being processed for the delivery of a baby that they can experience that as dehumanizing, and they can come out not only depressed, but traumatized. And the trauma impacts their health, impacts their parenting, impacts their family and their community at the end of the day. So what we're talking about is really expanding the picture within the system to recognize what would it look like to recognize the full spectrum of human rights, and how would that change the way things are done.
So that's exactly what we're actually getting into here, and how to then raise the awareness of caregivers, because we actually don't know how to tackle that issue. Because once women start raising their voice, they don't get heard, because again, we still remain in that survival mode. So maybe like what would really help us would be like to provide us with some sort of like tools, how to raise awareness both in lay public, because there are many women who still operate in the intense patriarchal mode of like having an external authority telling her what to do and what not to do and what is right for her. Mm-hmm. So she actually gives her power and decision-making capacity to someone else, and being that doctor or nurse or whoever. And then, so how to raise awareness both in lay public and in also medical professionals, in terms of that the woman actually is an authority in her own right, able to make decisions for herself.
The law requires that all the medical professionals put the patient's voice at the center of care through the law of informed consent, because the law requires that doctors and midwives, before they treat, that they explain what they want to do and why they're proposing to do it. They explain what the risks are of the thing they want to do and the benefits. They talk about the other options, other alternatives for treatment and the risks and benefits of those. They look the person in the eyes and say, do you have any questions? Answer all their questions. And then they support that person in making an informed decision. This is universal human rights. This is universal bioethics. It is the law. And so, but there's a gap everywhere, not just here, between the law of informed consent and the culture of obstetrics, which is not used to following the law of informed consent. And so when you say, the solution, the system needs to hear the voices of the women talking about their care. And that's what Kristýna is describing, is actually listening to women and understanding the impact on them, because there's different ways to get to a live mother and a live baby at the end of the process. And some of those ways are going to leave the woman feeling empowered, supported, joyful, healthy. And some of those ways are going to leave her feeling victimized, broken, injured, and traumatized. And so we have choices about how we're going to do things. And we're only going to make the choice that humanizes her if we think that she matters. So, I think a foundational question would be, what are some of the barriers within the system to women's voices really being heard? Is it because there's the way we do things around here, but there's also the fact that obstetrics was developed in an era where women didn't have any rights and their voices were not heard legally. They did not even have a legal voice or a social voice. And that theoretically has changed. Now women have rights, we can have professions, we can be in public space, and yet obstetrics has not really caught up with that reality. So there's still kind of an expectation that the woman is going to be passive, obedient to whoever is standing in front of her, but that's not a rational expectation of the system when C-section rate varies, episiotomy rate varies, practice varies from hospital to hospital, doctor to doctor. It's not fair or rational to expect a woman to just obey whoever's standing in front of her, and we're going to say that's the safest thing to do. Women who are informed are going to want to make informed decisions and get accurate information to do so. And I guess when you say, what can we do to raise awareness in the public about using their voices, because maybe some of them don't, it's making sure that when the ones that do get heard, because what's the point in trying to use your voice when the few who don't, their voice is ignored? Then we say, oh, the others aren't using their voice. Well, why would they? Because the two that did got slapped down. So look after the two that do use their voice and make sure that their voices are heard to open the door for all the others to try to use theirs.
Well, thank you. And also, I think I would just point out that the thing that we have been trying to do here for like 30 years now is actually finding the right way or the right ways how to crack the system open in order to make the professionals hear women's voices, actually.
Well, maybe, Kristýna, you could tell us more about when you hear the women's voices and they're talking about what kinds of experiences leave them feeling distressed about the birth itself. What are you hearing? Are there patterns that you're hearing about? Yeah. What are the patterns you hear?
Yeah, thank you. It's usually just the same pattern, and it's not, they are a lot talking about obstetric violence, but it's not violent. This can be just a few words said afterwards, like the baby, for example, the baby is at least from half mine because I pushed it out, not you. Or not every woman is able to deliver baby naturally. And, she had vacuum extraction done, and then it led to half a year of severe depression because her role as a woman and her role as a mother just didn't happen. She felt like she's good for nothing, that she's not good enough mother, not good enough woman, not good enough wife. Yeah, and it's, it's just paradox that how a little bit of words can destroy life of the family, the life of the woman.
It's so true. It's like women having a baby, they're vulnerable in so many ways, right? They're physically vulnerable, but also it's like their emotional field is open. It's because something profound is happening, right? They're in this transition into becoming a mother. And the one way I think about it is like a woman having a baby is at her most powerful and her most vulnerable at the same time. And the way she's treated by the people around her is going to amplify one of those states. And so she'll either come out feeling more empowered than she ever has because they supported her, or she'll come out feeling, more vulnerable and more disempowered. And when I hear the vacuum story, what I wonder is, what happened around the use of the vacuum? Because when I see the women coming out traumatized from the vacuum, it's like, say, doctor comes into the room because the screen went blip, and doctor stands, but is now between the woman's legs holding a vacuum, and the woman saying, "What is that? What's going on? Is something wrong?" And even the husband is saying, "What's going on, doctor?" And they are just ignoring. The doctor's just ignoring. But it's not like there's no time for a conversation. 10 minutes is passing as the doctor waits for the baby to come down more. But the woman's frightened because she senses something's going to happen, but nobody is saying what. And then as soon as the baby gets there, jam, pull. I've talked to women who come out suicidal from that experience. And the pattern, what women say about this kind of thing, but other things is like, if someone had taken 30 seconds to talk to me, to say, "Listen, my love, I sense the baby's having a hard time coming down. I have this tool. I could use it to help. And, and I'll be really generally these have some risk to your pelvic floor, but I'm going to be real careful with it. Would it be okay if I helped you in this way? And she says yes. These women say if someone had taken 30 seconds to talk to me, I would not have spent the next year crying on the bathroom floor, unable to mother my child. Is that consistent with what you see?
Yeah, exactly. I also heard a story where a woman had also a vacuum extraction done, and the doctor wasn't talking directly to her. He was talking to midwife, and he said her, teach her how to push. She felt like nothing. Mm-hmm. He wasn't addressing her directly. He didn't talk to her. At least, but I think a lot of obstetricians, when they are in a stressful situation, they experience a lot of fear. A fear for their reputation, fear for money. They fear, they are going to be responsible if the outcome is not good enough. And they are also they are angry at the woman that she's not pushing right, that she's not cooperating right. That she didn't want the oxytocin when he told her she needs it. And now we need to do some emergency vacuum extraction. And I risk my reputation. I've seen it. It's it's not right.
I think the issue that we are addressing here is the fact that many people also, when they come in the maternity ward, are not aware of that. They think that their goals, as like the woman who is about to give birth, and the goals of the professionals who is going to look after her, their goals are the same, but they are not. And I think that this is something that the lay public should take into account as well. Could you please speak about, you have already started speaking about that, but could we please address that even more if there is anything else you would like to add? Their goals really differ. They do differ.
Yeah, because, doctors, they are people. And people, we have different backgrounds, we have different motivation. And, we are obliged by law to give the best practice we can according to the latest development and such. But, we are also people and we can manipulate, because sometimes, the situation is not black and white. There are some options. And we have the option to talk to the woman, talk to her husband about the options, or we can manipulate them.
Exactly.
Because, some doctors have a lot of ego, and they think that based on their experience, they are the best to provide care. And, they think that their ideas are the best. So they just tell the woman and tell the husband what he wants them to hear and manipulate them.
And specifically, informed consent can be invalidated by a number of different sort of activities on the part of the provider. One is manipulation. And what manipulation means is, what the law requires is that the doctor give the patient accurate information about the risks on all sides of their options. And manipulation, which is the way informed consent usually works, if there's even a conversation at all, is, well, let me tell you the benefits of the thing I want you to do and why it's such a good idea. And let me tell you the risks of not doing it or of following any other course. And I won't tell you the risks of what I want you to do. And I won't tell you the benefits of the thing that you could do instead. That's manipulation. And, again, there's a American College of OB-GYNs have this excellent ethics opinion from June 2016 on maternal refusal of medically recommended treatment. Totally worth reading because, again, they didn't make this up. They're just reflecting the law and bioethics. And they say pregnancy is not an exception to the fact that all patients get to make decisions about their care, even care needed to save life. So they're specifically addressing whether a doctor can say, oh, but the baby's in danger, because the baby's always in danger in childbirth. And so if that's your reason why the doctor would get to make the decision or be the authority, then that will always be a reason why the doctor can. But it's not the law of informed consent. And so what you were just describing, Kristýna, about the doctor saying, I'm the expert here, I know. Another case that obstetricians or policymakers here could read is Konovalova versus Russia, the case that went to the European Court of Human Rights in 2014 on informed consent in pregnancy. And it's a valuable opinion because they have, again, affirmed that pregnant women have the right to make all the decisions about their bodies in care. And they cite a whole lot of treaties to which the Czech Republic is a signatory that make very clear that the state must ensure that the doctors and the midwives don't say, I'm the expert here. They don't get to do that. Your expertise and your training and your knowledge give you the authority to offer the skills that you're trained in and be paid for those skills, to provide them in a way that is non-negligent and in a way that respects your patient's rights. That is the responsibility of the doctor. And the doctor is not responsible for the outcome. Nobody can be responsible for the outcome but the cosmos. You know what I'm saying? And so, because there's no place that can reduce death to zero. Death will always happen in childbirth. But when the provider believes that they are responsible for the outcome, they feel a lot of pressure to control the process, because how can I be responsible for something I don't control? That's why understanding the limit of the responsibility, what you're responsible for is what you can control, which is doing your job, using that vacuum carefully in the way you know how to do, in a way that respects her rights, which means you have to ask, even if you're uncomfortable. And the thing about informed consent is doctors and midwives can say, yeah, I believe in informed consent, as long as she does what I want. But the only time that you're really tested in your commitment to it is when she asks questions that make you uncomfortable and makes a decision that makes you uncomfortable, and you still support her. And so if the doctor or the midwife feels afraid, well, I'm vulnerable if I support her, then the next question should be, what do I need so I can feel safe to support her? What do I need from my system? Do I have to pivot and turn back to the hospital, turn back to my colleagues and say, look, this is her rights. We are all obligated to support her rights. And I feel like I'm stepping out alone when I do that. So I need to know that y'all have my back. And, or whatever the problem is. But what's not okay and what we usually do, which is saying, well, there's all these system dysfunctions, there's fear of liability, so therefore we're going to keep violate the patient's rights. These are human rights. They're inviolable. So therefore, if our commitment is to not violating them, then when we look at the system dysfunction, we can acknowledge it. Provider trauma is very real, and we don't have systems that are addressing the trauma and the emotional distress for the providers of the real emergencies. I've heard OBs telling me about a woman has a heart attack and she's on the floor and they have to do a C-section on the floor, or standing with rubber boots because there's so much blood on the floor. These are traumatic experiences where birth got out of control. And so that can lead the OBs who have not processed the trauma to feel like the only way survival happens is if I am in control. And midwives are scary because that's physiological birth is scary because that's out of control. But that's not really a rational conclusion from their previous experience. So we can treat their trauma and we can address it, but no longer use it as an excuse for the ongoing violation of women's rights.
So basically what we are talking here is about the distribution of accountability or responsibility at the maternity ward and while giving birth, actually. And the thing that perhaps Kristýna might address is that medical professionals here in the Czech Republic don't seem aware of the fact that they are not responsible for the outcome.
Well, and that's not just here. It's in many places. There's this a lot of the fear that Kristýna is talking about comes from this belief that they are responsible for the outcome. And again, that's if you really sit and talk through slow, they'll recognize they can't be responsible for the outcome. But just that discourse, yeah, it's even why, I also represent midwives, and I'll say to them, drop the language of lost a baby. You didn't lose a baby died. You know what I mean? Ditto in the hospital, right? So don't take on more than is actually yours.
So that actually also brings us to the subject or question, how is informed consent taught in medical universities? Like, how were you taught about the informed consent? How to navigate that?
They were not taught at all.
They were not.
And that's true so in so many places. So again, the obstetric violence is the gap between the law of informed consent and the culture of obstetrics, which ignores the law of informed consent. And if we want to eliminate it, all we have to do is follow the law.